Assalamualaikum, salam sejahtera, Om Swastiastu, Namo Buddhaya. Kembali lagi bersama saya Dr. Patrick Indrajaya dari Dokwiti Indonesia. Hari ini kita akan memulai webinar ini dengan penyampaian materi etik terlebih dahulu. Ini sedikit informasi mengenai kode etik kedokteran. Seperti yang kita ketahui, pasal 21 kode etik kedokteran bahwa setiap dokter wajib senantiasa mengikuti perkembangan ilmu pengetahuan dan teknologi kedokteran atau kesehatan. Yang dimaksud dengan perkembangan ilmu pengetahuan dan teknologi kedokteran atau kesehatan adalah termasuk aspek etik, kedokteran, disiplin, dan hukumnya. Seorang dokter wajib mengikuti kursus, pelatihan, dan acara ilmiah yang diakreditasi organisasi profesi, yaitu Ikatan Dokter Indonesia, guna memperoleh satuan kredit profesi atau yang biasa kita kenal dengan SKP, guna dapat mempertahankan kompetensinya. Surat tanda kompetensi ini pada saatnya menjadi syarat dalam memperbaharui surat tanda registrasi atau STR di Konsil Kedokteran Indonesia, guna mengurus izin praktik dalam siklus 5 tahunan. Pengamalan pasal ini dapat berupa mengikuti webinar yang kita lakukan hari ini. Semoga webinar kali ini dapat bermanfaat dan semakin menambah pengetahuan kita seputar topik yang akan dibicarakan pada hari ini. Sekian materi etik dari saya. Terima kasih. Good morning and good evening to you all. Assalamualaikum, Shalom, Om Swastiastu, Namo Buddhaya, Salam Kebajikan. Hope that you are in good health due to pandemic situations that happens across the globe. Today we could virtually meet with experts from 3 different continents and have a discussions about allergy and immunology topics, but still you could enjoy being at home. Let me introduce myself. My name is Patrick Indrajaya. I will be the host of today's event entitled The Microbiome, Prevention and Future Therapies of Allergy. A very welcome to distinguished speakers, Dr. Kalina Spenter, Prof. Ruby Pawankar, Prof. Chu Yao Wang, and Prof. Alessandro Fiocchi. And also our moderators, Prof. Iris Rengganis, and also Prof. Heru Sundaru, and all participants from different countries that already joined the webinar. This event is held by collaborations between Asia-Pacific Associations of Allergy, Asthma, and Clinical Immunology, and we used to call it APAAACI, with Indonesian Society of Allergy and Immunology, or ISAI, also Jakarta Allergy Immunology Network, and the last is Dokwiti Indonesia. Before we begin, we are very honored to have Prof. Ruby Pawankar as the president of APAAACI to officially open the webinar and deliver a welcoming speech. Prof. Ruby, the floor is yours.
Thank you very much, Patrick. I would like to express our deepest gratitude to Prof. Iris and Prof. Heru, to the Indonesian Society of Allergy and Immunology, and to Jachin, who have been partners, and the ISAI is our national member society, for this wonderful opportunity of collaboration together to bring together a good science and good information to our membership and beyond. I give my warmest greetings to the Indonesian Society of Allergy and Immunology and to Jachin, and look forward to this very good session. We are very happy to have with me the president-elect of APAAACI, Professor Jiao Wang from Taiwan, who will also be giving a talk. Very happy to have Professor Kalina Spenter from Denver, who will be giving a talk. And I'm also happy to have Professor Alessandro Fiocchi, who's also the advisor to our Food Allergy Committee, to give a talk. So we have several people giving the talk from the different continents, but this important aspect is the real collaboration for science and for the specialty between all of us, and the opportunity to interact with all our membership and our community around Asia and beyond. So with these words, I would like to end my welcome, and I would hand over to the moderators. Once again, thanking the society, our moderators, and all our speakers in advance, and to Patrick and his team for organizing this. Thank you.
Thank you, Prof. Ruby, for the heartwarming welcome speech. Now we will continue with the most exciting parts of today's webinar. The main talks are divided into two sections. Let's start with the first section that is moderated by Prof. Iris Rengganis. Who doesn't know Prof. Iris in Indonesia? So each speaker will have 25 minutes for presentations, continued by question and answer. And Prof. Iris, the floor is yours.
Thank you, Patrick. The honorable Madam Speakers, distinguished guests, fellow students, ladies and gentlemen, good morning and good evening for certain countries. Assalamualaikum warahmatullahi wabarakatuh. I'm Iris. It is my honor to be a moderator for this session. First of all, I would like to welcome you all to this prestigious seminar about the microbiome prevention and future therapies of allergy, held by the collaboration of APAAACI, Asia Pacific Association of Allergy, Asthma and Clinical Immunology, and ISAI, Indonesian Society of Allergy and Immunology, and also JACIN, Jakarta Allergy and Clinical Immunology Network. This webinar also supported by DocWitty. In this occasion, we shall have outstanding presentation from our prominent speakers, whom I believe shall enrich our insight and knowledge regarding the theme of the seminar. Before the presentation begins, allow me to introduce the first speaker, Dr. Kalina Spenter, is the Associate Professor of Pediatrics, Section of Allergy and Immunology at the Children's Hospital and University of Colorado, Denver, where she is conducting research in allergy prevention and working with children with food allergies. She is a member of American, European, and British allergy societies. She moved from the UK in 2015, where she performed research into food allergy prevalence funded by the Food Standards Agency, UK. She is a member of European American Food Allergy Guidelines on Allergy Prevention. She was also a member of the NICE UK and National Institute for Allergy and Infectious Diseases Food Allergy Guidelines. Before the presentation, already introduced the first speaker. Without further ado, I would like to welcome Dr. Kalina Spenter. She will deliver a presentation entitled Alteration in the Microbiome in Patients with Food Allergies, Implication for Prevention, Management, and Treatment. The time is yours. You have 25 minutes to present. Is still unmute. Dr. Kalina is still unmute. Yeah.
Your voice is not appear.
The voice, we don't hear your voice. Please check your mic.
Dia kan nggak dengar, tapi nggak bisa lihat.
Dia bisa dengar.
Bisa.
Maybe try without your earphone.
Now, can you hear me?
Yes.
Yeah, it's clear now.
Can you hear me?
Yeah.
Yes, clear.
Good. Okay, well, now I can't hear you, but thank you for the introduction. And I would like to share today with you information about alterations in the microbiome. And I am just going to show you the slideshow. Good. So alterations in the microbiome in patients with food allergies, implications for prevention, management, and treatment. So the objectives of my presentation will be to discuss the role of the microbiome in the prevention of food allergies. That will really be the bulk of my presentation. I will also talk about the role of the microbiome in the management of food allergy. There's not much that we know about that, but we do know some information about the management of cow's milk allergy. And then I will talk about treatment options, which I think is a very exciting field that we now have in terms of the food allergy arena. So dysbiosis is basically a loss of balance in the gut microbiome. The next slide show it very nicely, I think, where you can see where you have the commensal bacteria present and they are in a balance. We get an upregulation of the T regulatory cells and particularly an increase in TGF-beta and IL-10, which are the classic cytokines associated with the T regulatory cells, and that is presented as tolerance. On the other hand, we can get an overgrowth of pathogenic microorganisms, and that is presented as a breakdown of tolerance. So a balance in the commensal bacteria, particularly with presence of some probiotic bacteria associated with tolerance in the gut, and then also tolerance to food allergens. And I will go through these again in detail. So looking then at the next slide and giving you some information about what we know about the microbiome in food allergy, it's really surprising when we think about how often we talk about this topic and the fact then that you know, we have so few studies. So the first study that I would like to share with you is the data from Megan Azad from the child study in Canada. And you can see here how she compared the microbiome in infants sensitized to food allergens at 3 months of age. We have to remember the numbers were pretty small, only 12 were sensitized, compared them to the non-sensitized infants. And then again, she looked at the sensitized infants at 12 years of age compared to the non-sensitized infants. And I don't want to get into the detail of the different species and phyla present, but you can clearly here see how the gut microbiome composition really differed in terms of relevant abundance of different bacteria in the sensitized versus non-sensitized kids at 3 months and then again at 12 months. So then we may wonder whether the microbiome plays an effect in outgrowing food allergy. And so this is data from the COFAR study in the United States. It's a multi-center study. And the associations in B and C in particular were not statistically significant, but you can actually nicely see how the alpha diversity measured by the Shannon Diversity Index differed in children that outgrew their cow's milk allergy at the top line. So the children with a higher diversity in their gut microbiome, they outgrew their food allergy much quicker than the children with the lower diversity. And here we can see it again at the different age groups. So this data showed, and that was done in 226 children, that children with increased microbial diversity has a higher chance of outgrowing their cow's milk allergy as children with a reduced microbial diversity. This is data from Shanghai published by Dong et al. And in this slide, you can see the children with cow's milk allergy is the inner circle at baseline and the inner circle again 6 months later. And then the children in the outer circle did not have cow's milk allergy at baseline and again their microbiome 6 months later. And very interesting to see how the microbiome diversity and species abundance differ between the children with cow's milk allergy in the inner circle at baseline versus those without the cow's milk allergy. We see a similar pattern 6 months later, but also interestingly to look at is to see how the microbiome changed from baseline to 6 months later in the children with cow's milk allergy and those without cow's milk allergy. This is children with egg allergy, again from the COFAR studies in America. And you know, quite often in food allergy, we find that 1 + 1 does not necessarily make 2. And so here we have the opposite of what I've just been telling you. We see an increased microbial diversity in children with egg allergy and a reduced microbiota diversity using the Shannon index in children without egg allergy. So it may also be that what we see in the well-studied samples of cow's milk allergic infants may not necessarily be true for children with egg allergy. But then when we look what happened in adults with peanut allergy, we see similar picture as we saw in the infants with cow's milk allergy, where once again, clearly we saw an increased microbial diversity indicated with a 0 in the group with peanut allergy versus those without. So I would say, other than the egg data I've just showed you, the data has been pretty consistent, showing us increased microbial diversity in children without food allergy and a reduced microbial diversity in children with food allergies. And then similar in this study looking in adults, and that was the American gut study. So, but then we wonder, okay, so when we look at diversity, are there any bacteria that's the good ones? Because, you know, as clinicians, we like to fix things. So, you know, which bacteria can we give infants to stop them from developing allergy? Or if they have allergy, how can we get them to outgrow their allergy? And so I'm really summarizing a very complex field in 3 columns on this table, where we can say that the firmicutes, and particularly the family Lactobacillus and the Clostridia family or genus, has been associated with reduced food allergy outcomes in infants. The data from Clostridia, particularly the data from Clostridia perfringens, is really based on mouse models more so than human data. And then we also have the actinobacteria or the bifidobacteria, which has been studied particularly in terms of Bifidobacteria breve, showing reduced allergy outcomes, particularly cow's milk allergy outcomes in infants with increased abundance of this bacteria. So to summarize again, what little bit we know now about the gut microbiome and which species may be of interest, we have got data on Lactobacillus GG showing a positive effect, i.e. reduced allergy outcomes. We have data on Bifidobacteria breve showing similar data to the Lactobacillus GG, and then the data based on Clostridia perfringens, which is mainly based on mouse model studies. But what I do have to say is, let's be careful. You know, we cannot just make a statement to say, oh, all firmicutes are good and prevent allergies, so all actinobacteria are good. Because on the next slide, I will show you that when we actually list bacteria in terms of different genus as families and species, that's been associated with increased numbers of food allergy or sensitization and reduced numbers of food allergy and sensitization, we can see that we get the actinobacteria on both sides of the table, we get the firmicutes on both sides of the table, and also the proteobacteria with the bacteroides only on one side of the table. So we have to be very careful just to try and extrapolate any data we find on one specific species or families in terms of prevention. We really need to study the specific species to know what their specific effect on the gut microbiome and clinical food allergy outcomes is. But then, you know, I sometimes think I have a very simple mind for this complex field of research that I'm involved in. And so my question a few years ago was, so why do we want this diverse bacteria, or what does these particular bacteria do, you know, in terms of the Lactobacillus GG or the Bifidobacter breve to prevent allergies? And it seems that the answer really lies in the production of butyrate. Now, butyrate plays it's a short chain fatty acid. It's produced by the colonocytes from fiber, dietary fiber, and I'll show you which fibers on the next few slides. And we know that butyrate is important because it helps to maintain the intestinal barrier function by increasing the tight junctions or strengthening the tight junctions, and also by mucus production, so the proteins literally can't slip through. It is an energy source for the colonocytes, again, to keep the colon healthy. And it's very important in terms of T-regulatory cell function, and higher levels of butyrates have, in numerous studies, mouse models as well as human data, showed an association with increased levels of IL-10 and TGF-beta, which we know has been associated with tolerance induction. And so then my next question is, so if we know that butyrate is that important, what can we eat, you know, to make butyrate? Because perhaps we can just shortcut this whole process of wanting increased gut microbial diversity or trying to nurture particular microbes in the gut. If we could just eat something that's going to give us butyrate, then perhaps we can fix the whole situation. But it is not that simple, because the bacteria in the gut is crucial for the production of butyrate. So we will get to what we need to eat, but we're also going to need two particular strains of bacteria. And it seems that the bifidobacteria and the firmicutes, in terms of the lactobacillus, play a combined role in terms of butyrate production. So what we do need is do need the bifidobacteria to convert the oligofructose or the inulin to lactate and acetate, and then that is converted into the butyrate by the firmicutes. So you can see it here nicely summarized. We need the process to be started with the bifidobacteria, and then once we've got the lactate and the acetate, that is broken down by lactobacillus species into the butyrate that we need. So we really can't just get rid of the important role of the microbes in the gut, or perhaps probiotics in the gut, in terms of butyrate production. But getting back to the diet, you know, and getting back to let's just eat butyrate, there's actually two foods that's very high in terms of butyrate content, and that is ghee and butter. But I will also show you on the next few slides that a high saturated fat diet has been associated with reduced microbial diversity. And we also don't know whether the butyrate we eat from food gets into the colon intact. So I think it's an interesting concept, but we're nowhere near the point where we can say by feeding infants a lot of butyrate and butter, we're going to prevent their food allergies. So let's watch this space. So how can we then enhance butyrate production in the gut if we've made sure that we've got a diverse microbiome with sufficient numbers of bifidobacteria and lactobacillus? What can we eat to help the process? And there is one particular strain of fiber, the arabinoxalan, I really struggle with the pronunciation, which is a fiber, a hemicellulose we particularly get in rye, barley, and wheat. And so it does look like containing wheat in the diet, in particular the fibers from the grains I've just listed, may be very important for increased or enhanced butyrate production in the gut. I'm not taking away anything from the fibers that we find from fruit and vegetables and other grains, but these three grains may need to be studied more in terms of their butyrate enhancing functionalities. So then we also look at studies from Caroline Riday's work, and she looked at early diet in the first year of life and how that associates with butyrate production. And what she found was that the infants with diets high in yogurt, fatty fish, fruit, and vegetables, so she didn't actually look at grains, had increased butyrate production, increased T-regulatory cell function, and then clinically they also saw less allergy outcomes, in particularly also food allergy outcomes in these infants at 6 years of age, when they had more butyrate production in their gut in early life, so in the first year of life. So then we look at the early infancy diet, because the question is, so if we have an increased diet diversity in infancy, can we then increase the microbial diversity? Nobody has done a direct study looking at infant diet diversity and microbiome diversity. But when we just look at simple increase in family food during the weaning period, we can see that as the child eats more food and therefore have a more diverse diet, they have increased microbial diversity. The same is true for increased fiber intake and increased protein intake, But as I've already alluded to, high fat intake, the more fat the infants are eating, the lower the microbial diversity. So again, we don't really want to push very high fat intake in young infants. But clinically, does it matter? You know, so if we have a more diverse diet, do we tend to see less allergy? And you might have seen this slide from me in the past. I'm very proud of this paper. I worked 10 years to get this data. But what I've showed from my data on the Isle of Wight was that when we have increased diet diversity in the first year of life, we see reduced food allergy over the first 10 years. And that is true for increased food intake by 6 months of age. So these babies were introduced to solid foods early, and the more solids they had by 6 months of age, the least likely or the lower the odds of them developing food allergy by 10 years of age. And very interestingly, the same was true for food allergen diversity. So the more food allergens they've eaten over the first year of life, the less food allergy we saw by 10 years of age. And strikingly, each additional food by 6 years reduced the odds of food by 6 months, reduced the odds of food allergy by about 11% at 10 years of age. And for each additional food allergen given, the odds of having a food allergy by 10 years of age were reduced by about 33%, a third. So really the message is let the babies eat. And the next two graphs just really summarize what I've just shown you. More foods by 6 months of age, reduced odds of food allergy by 10, more allergens given by 12 months of age, reduced odds of food allergy by 10 years of age. So that's sort of like prevention wise, you know, I think what we can say in terms of prevention is let's try and increase diet diversity to increase microbial diversity. But now we have a child with food allergy, and what can we do? I often wonder, you know, what we should do in terms of the underlying diet when we give food avoidance advice to children with cow's milk allergy, peanut allergy, egg allergy, and particularly children with multiple food allergies. And so here you can see that in children, when we give them more fat to eat, we give them less fiber to eat, and we give them more protein to eat, their microbial diversity comes down. And so perhaps this is not a group of children with food allergy, but perhaps there is a message in this for us that if we want to induce tolerance in children with food allergy, perhaps we should also make sure that they eat more fiber, less fat, and moderate amounts of protein. Because really eating a high amount of fat and a mixture of fat can actually reduce microbial diversity within 48 hours. But the good news is we can correct it with eating more fruit, vegetables, and probiotics in yogurt. Advanced glycosylated end products, so frying foods, can also negatively affect the gut microbiome. Even foods that we think is good, like roasted almonds and roasted cashews, have got very high amounts of advanced glycosylated end products. And so perhaps in this time where we're telling babies or families that the baby should eat more of these nut allergens, we also need to look at the way that the allergens were, or the nuts were manufactured. We also need to look at emulsifiers in the diet, because some emulsifiers can negatively affect the gut microbiome. And then the question is always about supplements. Should I be giving my child more prebiotics, which are fiber, more probiotics, the live bacteria, or the two together, the symbiotics? And in this point in time, it's very simple. The preventative effect of pre, pro, and symbiotics may only be focused on atopic dermatitis and food allergy sensitization, but in terms of food allergy outcomes clinically, it doesn't have an effect. I'm quickly going to go through the next few slides, but I do want to show you that in terms of using probiotics or symbiotics, so giving a probiotic with a fiber, a prebiotic, in the treatment or the management of cow's milk allergy, we really only have data on Lactobacillus GG, but clearly giving them an infant formula with Lactobacillus GG increased their butyrate production. And also when we give infants a formula containing bifidobacteria with a prebiotic, we see an increase in microbial diversity. I'm not going to discuss the clinical effects of these formulas today because I'm really focusing on the microbiome, but we can see that giving lactobacillus and giving bifidobacteria plus a prebiotic at least change the gut microbiome structure and function. Clinical effects is always the most important thing to focus on. There's some good clinical data to show that the LGG may help with outgrowing cow's milk allergy, and the data on bifidobacteria with prebiotic in terms of outgrowing cow's milk allergy has not been published yet. And then treatment, my last 3 slides really is just to say this is fascinating data from Kalina Doe's group in Stanford, showing that as adults was undergoing peanut OIT without giving them any probiotics, their microbiome changed. So the microbiome became more diverse as they were eating more peanuts. That also brings the question, perhaps, what else is there in peanut other than the peanut protein that may be inducing tolerance? This was also in line with a study published from Mimi Tang from Australia in children, where she showed that if you give peanut OIT plus a probiotic, it was Lactobacillus GG, that there's much higher sustained unresponsiveness. So they were still being able to eat peanuts after 2 weeks of stopping the treatment, and that she also reduced sensitization, or she desensitized them, which at least meant that there was a transient increase in being able to tolerate peanuts. So this study showed that giving peanut OIT plus a probiotic enhanced outgrowing peanut allergy, or enhanced at least sustained unresponsiveness. The problem, however, with this study was that there wasn't this middle group that had peanut OIT only without the probiotic. So it's not really easy to tell what was the effect of the peanut OIT and what was the effect of the probiotic in combination with the peanut OIT. And then we are moving into exciting times where we're doing fecal microbiota transplantation, where we're literally transplanting fecal or stool samples from a healthy person to somebody with disease. It's very difficult to define what healthy means. So just because you don't have a food allergy, does that mean you're healthy? You may be suffering from depression. You may have IBD, you may have a tendency to have cancer. And if we are transferring stool samples from a healthy donor with some disease, are we actually increasing the risk of the person who received the donor sample to increase perhaps their chances of having cancer or developing depression, even though we are fixing their food allergy? So really, in terms of fecal microbiota transplantation, we still have many things to learn about picking the perfect healthy donor and how to define these. But, you know, murine models looking at food allergy outcomes have shown a positive effect of transplanting fecal samples from a mouse model or mice without food allergy into those with food allergy and resolving the food allergy. And there are currently human trials underway funded by the NIH. So I think, you know, we're at no point where we can do these kind of transplantations clinically in our patients, but we can at least keep our eyes on these exciting trials that's currently being conducted. And so with that, I'm going to summarize what I've just said. The gut microbiome has been associated with food allergies, this clear. It's clear in terms of diversity and that there's some specific species that may be important. We know that diet may help to modulate what's going on in the gut, and particularly fiber intake, perhaps probiotic intake in yogurts and fatty fish. It's exciting times in terms of oral immunotherapy. We really need to understand better how that interacts with the gut microbiome. And then FMT trials are currently in progress, and we eagerly awaiting to see the outcomes. And if you do want to learn more about pediatric food allergy, I know that this will be placed on your website as well. There is the link to register for an online course over 9 months, led by myself and Marian Gruch from Mount Sinai, teaching the nutritional aspects of managing IgE and non-IgE mediated food allergy. So I thank you very much for your time, and I'm happy to answer some questions. I think I've left a little bit of time for discussion.
Thank you very much, Dr. Kalina, for your informative and interesting talk. Very well, ladies and gentlemen. Now we come to the question and answer session. I see here already one question from Professor Eddie. The question is, what is the role of T helper 17 and T regulator in colon?
Okay, well, I'm gonna, the T helper 17 cells, I haven't studied myself yet, so I'm gonna pass on that one. I don't know if any of the other speakers may be able to help. But the T regulatory cells, you know, and particularly their cytokines, the IL-10 and the TGF-beta, and when there's increased levels of IL-10, TGF-beta, we know that there's a downregulation of the Th2 cytokines, and therefore we see less sensitization to food allergies, because basically what you're doing is you're introducing allergens into a friendly gut, or not an unfriendly gut, which is more prone to tolerance development than a gut that's got very high levels of the Th2 cytokines, where you're more inclined to see more sensitization. But Th17 cells, I haven't studied that in the gut. I know that it's been studied by Liam O'Mahony in terms of the microbiome in the lung. But again, you know, I've always focused my research more on the gut and food allergy than asthma and the lung.
Yeah, okay, thank you. And one more question for you. You mentioned from Dr. Stephen Sumantri, you mentioned about rye and wheat for microbial diversity. How about the role of gluten sensitivity in intestinal permeability?
Yes, again, you know, I'm not an expert in celiac disease, but and I have been looking at the celiac data, and also, you know, in the inflammatory bowel disease data, where often they take these grains out completely. Clearly, you know, we see a change in the microbiome, but nobody has really studied whether it is directly related to taking the grains out. So I think, you know, we've got so much to learn about the gut microbiome and how that interact with the with specific kind of fibers. But we are now conducting a study with a group in Montana, really defining the different bacteria in the gut diversity, and specifically look at just fiber intake and different types of fibers. So I think in terms of the celiac disease people, it must have an effect on their gut, but I don't think that it's particularly been studied, just focusing on fiber.
Yeah, okay. One more question. We have still time for 5 minutes. The same name with you, from Dr. Karina Andini, the same name, to Dr. Karina. What is the doses of the prebiotic you recommended? The doses from the prebiotic.
That's funny. People ask me that all the time. I don't actually recommend probiotics. I know that people say to have an effect, it's got to be, if you give a probiotic, it's got to be above 10 to the 9th in terms of, so it's like 9 billion bacteria. At this point in time, I think I also don't recommend prebiotics. I think, you know, we really have to focus on just fixing children's diets. You know, when children come and see us in clinic and they eat burgers all the time, you know, the very first step is just to get them to eat fruit, vegetables, reduce the fat in their diet, get them to eat probiotic yogurts, get them to eat more fatty fish. So that would be the bulk of my dietary consultation, and get them to eat whole grains, because quite often they constipate too, you know, so you can get them to get whole grains. I think you can get the pre and probiotics you need just by a healthy, varied diet. And actually, I'll say one more thing about that. The American Gut Study showed that if you have 30 plant-based foods in your diet every week, that is your best chance of having a really diverse gut microbiome. So we have a gaming clinic where I get the kids to count how many plant-based foods they have a day, and we try and get to 30. Not adult portions, it's of course children portions, but we do try to get the diet as diverse and varied as possible.
Yeah, okay, thank you. This the last question from the president of the APAAACI, Prof. Ruby Pawankar, please, if you have a question.
Thank you, Prof. Iris. Thank you, Prof. Kalina. It was a brilliant lecture. We deeply appreciate your contribution to this conference. I especially was very much interested in the recommendation of introducing diverse foods at early age before 6 months, because the World Health Organization strongly recommends to have just breast milk in the first 6 months of life. And this important aspect of introducing diverse foods early in life could also probably have an impact on other non-communicable diseases beyond allergy. So just wanted to understand, how could we go ahead in kind of trying to convince, and what do we need to do exactly in this direction?
So an excellent question. And I tell you, I have spent this whole week, on so many phone calls about dietary guideline committees and breastfeeding committees and allergy committees, because I'm not sure if I'm going to give you an answer, but what I can tell you is there's a big disjoint at the moment between nutrition recommendations, breastfeeding recommendations, and allergy prevention recommendations, because all the allergy international societies, anyway, the ones that I've been involved in, Australia, United Kingdom, Canada, America, Ireland, South Africa, recommend that introduction of foods can happen around 4 months of age. So they say around 6, not before 4, and that as soon as the infants start food, they should start introducing the allergens. And that was initially recommended for infants with eczema only, but the guidelines are now saying all infants. Whereas, as you said, rightly so, the WHO still recommend exclusive breastfeeding up to 6 months of age. So what we have now done in the United States, and I've literally presented the data today, so it's hot off the press, is that we are saying that ideally an infant, if they start introducing solids by 4 months, so before 6 months, we should not give more than 100 calories coming from food, because at that level, it doesn't negatively affect breast milk production. And that 100 calories could then be like 1 or 2 teaspoons of at least 3 or 4 different fruits, and perhaps alongside some peanut. So when we talk about diversity before 6 months, we're really not talking 100 foods. We're really talking perhaps 4 or 5 foods. But I think the point that I was trying to make with that as well is, if we do start with that, if we have a hungry baby and we start giving solids from 4 months, don't just give them baby rice, or don't just give them applesauce as they do in America. Let's make it diverse in small amounts, but don't just stick to one food. As soon as they can eat and want to eat, think variety, even if the variety is only n equals 5 or n equals 6. I hope that makes sense. But, I cannot say this many times enough. If a baby is not ready to eat before 6 months, we should not force food into the kid for the sake of allergy prevention. I see many babies, they're happy, healthy, thriving, breastfed babies, 6 months of age. And I say to the mom, you're doing great. Please don't say you feel guilty because you haven't given peanut 2 months ago. It's perfectly okay. It's only for the babies that's ready to eat and hungry where I would give this advice. But my happy breastfed babies, I'm happier than anything to just let them breastfeed.
Thank you very much. I deeply appreciate the answer.
Okay, thank you, Professor Kalina. There are still many questions, but later on we have a panel discussion again after the first speaker's talk. Okay, now the time is over for the Professor Kalina. Thank you again for your informative and interesting talk, and to the audience for your active participation. Now, ladies and gentlemen, let's welcome to the next speaker. Before the presentation begins, allow me to introduce the second speakers, Professor Ruby Pawankar. Professor Ruby Pawankar is the president of the Asia Pacific Association of Allergy, Asthma, and Clinical Immunology, or APAAACI. She served as Board of Directors, World Allergy Organization, WOW, for 7 years and was President, WOW 2012 and 2030, and the first woman president to the head of the organization. She is also board member of the Collegium International Allergolicum and Interasthma. Professor Pawankar is a graduate from Armed Forces Medical College, postgraduate from BGMC, and doctoral fellowship in allergy and clinical immunology from Nippon Medical School, Tokyo. Professor Pawankar is the head of the Division of Allergy, Department of Pediatrics, Nippon Medical School, Tokyo, Japan, and a guest professor, Showa University School of Medicine, Tokyo, Japan. Now, before the presentation, I would like to welcome Professor Pawankar. She will deliver a presentation entitled Guidelines for the Prevention of Allergy Disease, Glad P. Time is yours, Professor Ruby. You have 25 minutes.
Thank you very much, Professor Iris, for this kind opportunity for giving this talk, as well as for hosting the collaboration with APAAACI. In the next 25 minutes, I try to talk about the primary prevention of allergic diseases, which is a great challenge, focusing on the GLAD-P guidelines, which actually is an initiative of the World Allergy Organization, was done during my presidency of the World Allergy Organization, and an initiative led by Professor Alexandro Fiocchi, who will be speaking later along with me and other colleagues in collaboration with McMaster University's group, Professor Holger and his colleagues. Oh, I can't go forward. Okay. Before I go into this, I just like to highlight one of the papers that we published in 2012, which was looking at the prevalence or patterns of food allergy in children globally. And this was done basically through our member societies. So it was a survey. So it's just looking at what is the published data. And if there was no published data, it was more of from the impressions that they had. And if you looked here, we had published data available from 23 out of the 89 countries. And of those, the OFC proven food allergy are in black, and those were based on symptoms and sensitization. That's the second level. And those that were with parent reporting, that's the third level of evidence for food allergy. But the general trend was in children ages 0 to 18, there was a marked increase in the prevalence of food allergies across the different countries. Now, this was actually looked at in a more specific way, where food challenge was used as the parameter to diagnose food allergy prevalence. And this study was done by Mike Levin and his group, and this is looking at the IG-mediated food allergy prevalence in children less than 5 years, and they gathered data from these different countries. And as you can see here again, you can see that in children less than 5 years, the highest level of evidence with food challenge also shows an increase in the prevalence of food allergies across the different countries and across the different continents. So when we talk about the microbiome, we've heard an excellent lecture from Professor Kalina Spenter, who's given us a detailed description about the microbiome and its impact on allergies, especially, of course, food allergies. But let's also see what other diseases are affected by an altered microbiome. So there are a variety of non-communicable diseases like Crohn's disease or ulcerative colitis or irritable bowel syndrome, besides allergy, also celiac disease, diabetes, obesity. A variety of these diseases have a strong association with an altered microbiome. So what's really the content of what I will talk now will be actually looking at the early life being a crucial period for the development of allergy factors that could influence allergy prevention. what are the guidelines they're telling us about allergy prevention? Is there any evidence? What does the GLADP guidelines talk about probiotics? And what does the GLADP guidelines talk about prebiotics? So this is looking at some of the factors. And in fact, we've also done, in our birth cohort, our studies also show a similar data of the relation between antibiotic use and microbiome maturation. So as you can see here, unexposed and exposed very clearly shows that an early antibiotic exposure leads to significant delay in the microbiota maturation during the first 6 to 12 months of life. And in our data, we've also shown a lower diversity of certain microbiomes in those children who were exposed to antibiotics in early life. There are other factors also, like this cesarean section, which also has an important role in affecting the microbiome in early life. And this actually is looking at the antibiotics and in early life. And you can see here, antibiotics, birth mode, and diet shape microbiome maturation during early life. And here you can see the type of bacteroids, and you can see vaginal and cesarean section, and showing a lower diversity in cesarean. This is also similar to what our studies, our birth cohort studies in Japan that we are doing has also shown in the first 6 months that there is a reduced biodiversity in certain microbiome. So what do you do for breaking the immune tolerance or dysbiosis, which already has been touched upon by Professor Venter? Well, there are many clinical and preclinical examples of this gut microbiota mediated therapy. It can range from stool transplantation to targeted molecular inhibition of microbial trimethylamine synthesis, to Bacteroides fragilis, various specific commensals, engineered E. coli, and early life supplementation. So let's look at what do probiotics and what do prebiotics do. We know that probiotics are live microorganisms which, when administered in adequate amounts, can confer a health benefit on the host. And this study looking at the effect of the probiotic on atopic dermatitis, this is looking specifically at Lactobacillus GG, has already shown by Professor Venter the effect of Lactobacillus GG. And this is looking at the proportion of 2-year-old children with atopic eczema, showing a 50% reduction in the development of atopic dermatitis in these children that were given Lactobacillus GG. But what do the different guidelines say? This is looking at the APAAACI guideline in 2014. And if you look at this guideline and you look at what it says, again, very clearly that there is no clear recommendation for probiotics during pregnancy, no recommendation for probiotics during breastfeeding, and no evidence for probiotics to infants or children to prevent allergy. Looking at the 2014 to 2019 German guidelines, again, you can see that there is no specific recommendation for probiotics or prebiotics in the case of prevention of allergy. So the World Allergy Organization, in collaboration with the McMaster University, developed these guidelines for allergy prevention called GLADP, and I'd like to highlight just 2 parts of it, probiotics and prebiotics. But the structure of GLADP was designed to target different aspects, looking at probiotics, looking at prebiotics, looking at vitamin D, short-chain fatty acids, hydrolyzed formulas, and solids, which is allergen avoidance versus early introduction, where we have now a lot of data coming up in the literature. We have covered probiotics, prebiotics, and vitamin D. These have been published. The vitamin D needs to be reevaluated based on some new data, and these other aspects are yet to be actually evaluated. And these are evaluated by the highest level of evidence called the grade approach. And using the grade approach, the recommendations were made in this panel. Now, looking at probiotics in pregnant women and eczema, as you can see here, that the diamond is towards the left, showing that the beneficial effect of probiotics in pregnant women in preventing eczema. And when you look at actually this table here, you can see that it had no effect on the asthma or wheezing, no effect on the food allergy up to 1 to 2 years. And for eczema, on the other hand, there were 9 fewer cases of eczema per 100. Of course, this looks like a smaller number, but is a window of opportunity. And also I will talk about it in relation to food allergy in the latter part of my talk, but clearly showing that it does have a window of opportunity for preventing atopic eczema. What about probiotics in breastfeeding? Also, you can see the same pattern here, that probiotics in breastfeeding can prevent eczema in a certain proportion. And similarly, also probiotics in infancy have a similar kind of data showing that there is a preventative role of probiotics in infancy for eczema. But what about the pooled data from different strains? This is a problem, and this is needs addressing, because which probiotic? Are all probiotics seen? Can we give a carpet blanket statement that all probiotics can help prevent eczema? No. This is very important because, first of all, studies are not necessarily done using the same protocol. Studies are not done with the same strain, and more studies need to be done with a particular strain before we can actually recommend it. Now, as you can see here, only Lactobacillus rhamnosus GG has been studied in more than one randomized clinical trial, controlled trial, and showing its benefit on eczema. So the WOW guideline panel then moved to recommend using probiotics in pregnant women at high risk for allergy in their children, but considering all outcomes, the net benefit resulting primarily from the prevention of eczema. Similarly, it also recommended using probiotics in women who breastfeed infants at high risk of developing allergy, and also in infants who are at a high risk of developing allergies. But again, all these are based on the net benefit resulting primarily from the prevention of eczema and not on food allergies or on asthma wheezing. Now, having touched about probiotics, let's look at what prebiotics do. How do they influence? Looking at prebiotics in infancy and eczema, you can see a series of studies and a different prebiotics over here. You can see, and you can see here also the outcomes assessed are also different, but here very clearly eczema, adverse events, nutrition, and again, looking at eczema. But when you see the impact on eczema, you can see very clearly prebiotics in infancy and eczema, that there is a beneficial effect of prebiotics in infancy for preventing eczema. But here also for wheezing, there is a kind of beneficial effect you can see, and also for food allergy. But the question again remains, because which strain of it can really have that effect? So the WOW guideline panel suggests prebiotic supplementation only in not exclusively breastfed infants, both at the high risk and at low risk for developing allergy. And this is a conditional recommendation with low certainty of evidence. So higher values on possible prevention of allergies and a relatively lower value on the additional cost that will be incurred due to the prebiotic supplementation. Moving forward to the more recent guidelines of the Australian Society SKR, you can see here very clearly that both during pregnancy and for infants, the SKR guidelines do not recommend the use of probiotics in either of these situations. So, furthermore is the updated YACI guidelines for 2020, which again highlights no recommendation for or against. So it's neither for or against for preventing food allergy for the use of vitamin supplements, fish oil, prebiotics, probiotics, or symbiotics in pregnancy when breastfeeding or in infancy. But here the focus is basically for food allergy. But if we would say for eczema, I think the data is as shown in the GLAD piece. So in order to recommend probiotics for allergy prevention, the key factor, it needs to be proven that a specific probiotic bacterium or a mixture of probiotic strains given to the pregnant mother or breastfeeding mother or directly to the child, infant, reduces the risk of later allergies. Although systematic reviews and meta-analysis may be helpful, pooled studies using different strains don't give the answer, and therefore more studies need to be done specifically using the same strains to get the same kind of results before we can start recommending them clinically. So in conclusion, I'd like to say the GLAD-P has been a very, very excellent initiative done by the World Allergy Organization involving all our member societies. APAAACI is a member society of the World Allergy Organization, and Professor Fiocchi led this initiative. It was initiated during my presidency, but it's a continuous process, and we shall be working further on that also, and hope the studies as they come up would help us to get a more definitive evidence. The point that I would like to raise out here is that with our new information that food allergy sensitization can occur also to the skin, is there a window of opportunity that by preventing eczema, would it be able to indirectly also influence the prevention of food allergy? It's an open-ended question, but it's something that probably we need to look at through further studies and through better formulated studies across continents, because there is a diversity in the type of allergies, in the type of presentation of food allergies across the globe. So thank you very much for your kind attention. And I'd like to just introduce, this is our board of directors. As you can already see, Professor Jiao Wang, who will speak today on probiotics and atopic dermatitis. He's our president-elect. This is our conference in China, which celebrated the 30th anniversary of the World Allergy of the Asia Pacific Allergy Organization, APAAACI. Some of our past presidents are here. As you can see here, Professor Yu Young Kim and Professor Hiba Moon as our past presidents, and our board of directors and our speakers here. And we have many initiatives, including news and notes, updates, webinars, web lectures, e-learnings, and many collaborations with our member societies. We look forward to more input from all of you. Please join us. Please send us your ideas and your suggestions and how we can help work together towards helping the specialty to develop further in our region. Asia is a big region, is a very important region. There's so much of information here and so much of need here. So please let us know how we can help increase the development of education and training in this region, and how we can help you in your respective countries to do the same. Thank you very much for your kind attention.
Thank you very much, Professor Ruby, for your nice and very informative talk. Very well, ladies and gentlemen. Now we come to question and answer session. I see from the Q&A, there one question. I will see here. Yeah. Any role in geographical, cultural, and genetic variation in the role of important microbial species? From Dr. Stephen Sumantri. As we know, it's a symbiotic interaction cultivated in thousands of years.
Yeah. Well, geographical factors could play a role, because also, as Professor Venter has very clearly shown about the diet, I think the diet is probably one of the key, the most key issue, I would say, in not just allergy, but across the different non-communicable diseases. So we have a lot of diversity in the diet, the food we eat. We have genetic diversity, and therefore studies need to be done across the different continents, across different cultures, and they should be compared to understand the effect of a particular probiotic or prebiotic or symbiotic or any such intervention. So yes, geographical differences, ethnic differences could play a role in this kind of a diversity.
Yeah. One question more from Dr. Itrida Hadianti. There is a dysbiosis in skin microbiome on atopic dermatitis patients. How about the effect of probiotic and prebiotic supplement in skin microbiome? Can we give as orally or topical treatment?
Well, this is a question that I would like to answer, but actually, this is a question that Professor Jia Wang, our president-elect, will be lecturing on. So I would like to leave it for the panel discussion or readdress this to him after his talk. So I'm happy to answer it, but I think it's better that we discuss this after we hear his lecture.
Okay. Just wait. And then from for Dr. Kalina, from Dr. Elisa, how a person could have food allergy occasionally. I think this for Dr. Kalina maybe. Sometimes she could develop symptoms of allergy, but sometimes not with the same food. Thank you. That is from Dr. Elisa.
So yes, I mean, food allergy, if you're basing on just symptom, is the lower. Of course, it is an important level of information, but we need to know exactly what type of food and what type of symptoms were caused. Sometimes people are not clear and they misunderstand what food allergy is. So I think it's very important to understand what food has caused it. What was the form in which the food was eaten? Was it eaten along with a mixture of other foods? Was it eaten in a heated form or a raw form? What was the quantity of the food that was taken? Has this happened for the very first time? And what happens when there are no symptoms when the same food is taken? Are there any blood tests, skin tests, or food challenge done? I think these factors need to be evaluated before we can really pin down whether the person is allergic to that particular food. And of course, as I mentioned earlier, food challenge is the highest level of evidence to prove that the person has a food allergy to that particular substance. But yes, there are people who have taken foods and nothing has happened to them for years, and then suddenly they develop a food allergy. That is commonly known, especially with crustaceans, because this can occur later in life.
Okay. One more question. Maybe I will ask to Professor Ruby. Is gut flora and microbiome the same? And what is the microbiome test? Do you have a special test from the stool or from the blood?
Well,
Kalau saya tanya apa yang
Is gut flora and microbiome the
well,
same?
the gut flora comprises of a variety of microbiota, right? And the microbiome the stool samples are analyzed to look at the type of microbiome that is present in the gut microbiome. But as we talked about the skin, I mean, you can also look at the skin microbiome, you can look at the lung microbiome, you can look at the oral microbiome, nasopharyngeal. So all these are, you need to have samples from the different sites to analyze those kind of microbiomes. For example, if we want to look at, in asthma, we take lung microbiome, but again, depending on the type of sample you take, whether it's a bronchial alveolar lavage, whether it's a bronchial brushing, whether it's a bronchial biopsy, the pattern of the microbiota will differ. So you cannot compare two studies, one looking at the bowel sample and one looking at the bronchial biopsy. You need to compare both with the same. But for the gut microbiome, we usually use stool samples and they are analyzed. And the most important point is the gut microbiome is especially crucial in early life.
Okay, thank you again for your informative and interesting talk, and to the audience for your active participation. Ladies and gentlemen, finally we come to the end of the presentation. We would like to
Iris,
say
Iris.
hello.
Prof. Heru have some questions. We still have 5 minutes.
Sorry. We have still time, yeah? I think
We
3
have
minutes, yeah? Okay, Prof. Heru, you have a question for Professor Ruby, please.
Professor Ruby, why probiotic it may work in atopic dermatitis while not in other allergic disease?
Well, this is from the data that we have, that the grade approach that was done to evaluate. So it's basically analyzing the existing data. Why it has an effect on just eczema and not other diseases is still open-ended question as far as I'm concerned. Maybe Professor Wang or Professor Fiocchi later on can discuss this when we have the panel. But the key issue is that we need more evidence on the different strains. Right now, the evidence is limited to one strain. And so I think we need more data to give more solid recommendation. But yes, it's a very interesting point why only eczema and not other factors. The other point is eczema is probably the first manifestation that occurs in an atopic child compared to asthma or food allergies. So maybe that's also one of the reasons why eczema has a stronger evidence compared to others.
Thank you.
Okay, I think this is the last question. Yeah. Thank you again for your informative and interesting talk, Professor Ruby. Ladies and gentlemen, finally we come to the end of the presentation from session 1. We would like to say thank you again for all the speakers for their informative and interesting talk, and to the audience for your active participation. Hopefully the presentation will be beneficial for everybody. Thank you for your attention. For the session 1 is finished, and I will return the floor to Dr. Patrick.
Okay, thank you, Prof. Iris, for the moderator to become the moderators of the first section, or section 1. So now we will continue with section 2 that we will be moderated by Prof. Heru. So Prof. Heru, the time is yours.
Thank you, Dr. Patrick. Ladies and gentlemen, we are now entering the session 2. We'll have 2 speakers, famous speakers, especially in pediatric allergy. The first speaker is Professor Yu Yang Wang. He is the director of the Allergy and Clinical Immunology Research at the Cheng Kung University Medical Center. He is also a president-elect of APAAACI, board member of WOW, and now the president of Taiwan Allergy and Clinical Immunology. Now, time is yours, Professor Wang.
Thank you, Professor Sandalu. Thank you for your introduction. I would like to share my slide. So can you see the slide?
Yes.
Yes.
Okay. Okay, I will start it. My name is Jiyao Wang, come from Taiwan. I'm going to talk about the probiotic in atopic dermatitis or eczema. I think we have just listened for 2 excellent speakers speak about how the gut microbiome affects the food allergy, and Professor Ruby Pawankar speak about how the GRAPE that is using the probiotic to prevent the allergy disease in very young childhood. I'm going to talk about the atopic dermatitis. And atopic dermatitis, I believe everybody knows, is a very severe allergy disease, particularly in very young children. And you can see the frequency is also very high, and the skin will occur for a very inflammatory disease, and it's very itching and cause very damage for the quality of life. Not just only for the young children, the parent, how to care them is also suffer a lot. And then you can see this slide. This is from Taiwan. You can, in the last century, not just only for asthma and allergy rhinitis, the prevalence for allergy rhinitis and asthma in our young school children is rising rapidly, and also for the eczema is also increasing. So you can see within 10 years, the incidence for eczema is increased for more than 100%. So we will discuss about the development or the risk factor for the development for allergy disease. Actually, you can see this is a very multifactorial and very complex risk factor intertwined together. For example, genetic, if you got a high-risk parent, then still you got a very high incidence to become an allergy child. And also the gene and the environment, particularly in our modern society, the environmental change, how we feed, how we diet, and even the air pollution we suffer and we have living all affect our immune system and also for epigenetic effect. So this genetic and environmental factor intertwine together but cause the maturation for immune system that become a more type 2 inflammation response, such as producing for the IgE and also sensitized to our environmental allergy. And then one of the genetic factors that in our Asian people is that somehow our atopic eczema or atopic dermatitis is more severe and more frequent than the Caucasian people. And you can see from this slide, and it actually, we can see a lot of patients that suffer more severe disease for eczema. And then from study conducted in Singapore and in Taiwan, we found that particularly for susceptibility gene for atopic eczema is filaggrin. And then this filaggrin mutation is more common in our Asian people. So the manifestation for AD is like we were compared to the Western world. For our child to have atopic dermatitis, we got a more early onset of disease and also increase for disease severity and increase for the bacterial composition, and there were a predisposition to become flare for the atopic dermatitis. So this is due to the filaggrin, some of the mutation, particularly on the SNP polymorphism. So we can see from this slide that compared for the SNP, that was a susceptibility for the AD in the filaggrin that is more complex and also more diversity in our Asian people, such as in Singapore, as compared to the Irish people. And the Irish people is just only 4 or 5, and that is the SNP polymorphism that is more easy to have the mutation for the filaggrin. But still, we also want to know is that not just only for genetic factor, some of the environmental factor also affect our allergy disease. And if we see our common allergy disease, such as like atopic dermatitis, food allergy, and also allergy rhinitis and asthma, they all have the common pathological signatures. You can see that during the mucosa membrane, for example, in the allergy rhinitis, for their respiratory epithelial cell, they have a lot of eosinophil infiltration in there. And then in the food allergy, during our intestinal villi, also have eosinophil infiltration and inflammation. And in our AD, atopic dermatitis eczema, we have found the skin barrier have disrupted and thrive, and also barrier function is disrupted, and also a lot of eosinophil infiltration there. So even the bronchial asthma is actually a bronchial epithelial cell disease. So they have a common pathological symptom that is affected by the mucosa membrane. And the mucosa membrane have a lot of commensal bacteria we call the microbiota that will interact with our in our immune system. So actually, allergy disease is very interact with our mucosa membrane and to the outside world, not just only for the external environment like air pollution, but also interact with our internal environment, such as in our gut microbiota and gut microbiome. So this is a study coming from north part of Taiwan, and my colleague in Chang'e Memorial Hospital, they correct the food allergy patient and healthy control, they compare for gut microbiota. So you can see the bacterial oil percentage is very low, lower than 50% as compared to the healthy control. So in a lot of food allergy disease, you can see the gut microbiota the composition is different and somehow suffer for the lack of the bacterial oil. And then the other factors that will affect our gut microbiota in our young infant is some of the environmental hazard, particularly for the antibiotic use. So in our study, we have collect using the national database, and we have 263,000 young children, and we follow up for 5 years. And our question is to ask that if the child, if the newborn child have been exposed to the antibiotic or acetaminophen, is an antibiotic drug, is it possible that will increase for the odds ratio or increase the risk for allergy disease before 5 years old? So you can see from this figure, the dot line in the black dot line is the population that have never been exposed to the antibiotic before 1 year of age, and then the incidence for the AD is started for about 1.7 until at 5 or 6 years is below 1%. But in the green dashed line, that means that have been exposed to the antibiotic. So the risk for the odds ratio for the atopic dermatitis will increase about 100%, and that is the twofold increase. And then the red line is the exposure to just only for the antibiotic, and the blue line is the commercial for these two risk factors. And then they all show the increase for the atopic dermatitis ratio. And then not just only for the AD, you can see from this figure, the asthma, the prevalence for the asthma was increased after exposure to the antibiotic for more than 50% as compared to never exposure to the antibiotic. And the antibiotic also increased for the risk for the asthma. And we also show that you can see found the same pattern for the allergy rhinitis that will increase after exposure to the antibiotic. So actually, we found that if we use the national database and we have conducted for 2 birth cohort follow-up for 5 years, and you can see if they have been exposed to the antibiotic before 1 year old, they will increase for the ratio for more than 1/4, so 100% they will increase for the become atopic dermatitis. And the antibiotic will definitely affect with the gut microbiota, that particularly before 1 year old, because a lot of gut microbiome have been for persistent and for lifelong composition, and that is before 1 year of age. So before that, they will change the microbiota composition and become a dysbiosis. And this gut microbiota dysbiosis also will affect the skin. Particularly, we have found that skin microbiota is also in the AD child is different from the healthy child, and because they have found a lot of predominant strain, such as in the Staphylococcus epidermidis aureus, particularly in the aureus, there were aggravate for the AD lesion and cause the disease coming out. So this Staphylococcus aureus, they have not just only producing for alpha toxin, and they will damage for the skin barrier, and also affect for the skin microbiota. And then from the Korean paper, review paper, we can show that in the gut microbiota chain is a dysbiosis. They also affect the skin microbiota. So we asked the question: is it possible that we using the probiotic, such a prebiotic or probiotic, is it possible to change the course for the atopic dermatitis? Is it possible to prevent or even to treat? And then this is the seminal paper coming from Lancet. It shows that if we give the probiotic for the pregnant mother, and after the child has been born, and sustained to administrate for the probiotic for 1 year, and then this can decrease for the incidence for atopic dermatitis for more than 50%. So this is quite dramatic. So we asked the question: is it possible that if we can screen some of the beneficial probiotic from the very normal newborn baby, is it possible they can also have this kind of effect, like LGG? And in our lab, laboratory, we have a screen for newborn baby, and one of the strain we call the Lactobacillus gastric belong to the we call the gastric. And then in our lab, we found if the culture with spinoside or dendritic cell, they can increase for IL-12 and also IL-10. And we would like to firstly we were using in our animal model. So this animal model is that we sensitize the mice with a hot dust mite, and a challenge with the hot dust mite after 2 weeks, they will increase for their airway inflammation, and also they have a particular symptom for the asthma will come out. And before challenge, that we administer for the Lactobacillus gastric for 10 to 7 CFU low dose or 10 to 9 CFU high dose. We found that these 2 doses can effectively suppress for the lung airway inflammation. And quite interestingly, we found that just only low dose can have a more effect than high dose. And then you can see the non-eosinophil cell is decreasing after administration for the Lactobacillus gastric. So we are quite encouraged by this animal study. So we and also we found the suppression is not just only for Th1 and Th2. We found the particularly IL-17A producing cell were decreasing after Lactobacillus gastric administration. So we were interested: is it possible to use as a clinical trial, because Lactobacillus gastric is have been regarded as one of the probiotic strain. So we conducted this randomized placebo control trial using the Lactobacillus in our recruit patient, that is asthmatic children and also with allergy rhinitis. And it's very interesting. We found that after 2 months of treatment for the probiotic, they will decrease for the they will increase for peak flow rate and decrease for the asthmatic symptom. So, and more interestingly, not just only for asthma symptom were decreasing, we found that eye itching and they were in the probiotic group, there was significant decreasing after treatment, and also the allergy rhinitis symptom in the probiotic group in the we have used the child number to give the probiotic, and even child number we give placebo. That is, after we have finished our study, we know which group is belong to the trial group. And the more interesting is we found the skin, particularly some of the atopic child not just only have asthma and allergy malady, they also suffer for atopic dermatitis, and some of them were significant itching. And you can see that using the probiotic, they have a decrease for the skin symptom. So in next study, we will conduct a large trial. We'll recruit about 240 80 patients, and then divided into 4 arms. 3 arms have been treated with the probiotic, and then the other treated in the placebo control. So we are published in the Clinical Experimental and Medicine Allergy, and then this 240 child suffer with atopic dermatitis. You can see we have treated for the 3 months. And then we have divided in 4 arms. Is one of the using lactobacillus paracasea, and then the other for the Pawankar, and then the other the third group using the combination. We found all these 3 groups have a decrease for the score rate, so increase for improve for the atopic dermatitis symptom. And the placebo group, even their symptom was decreasing, but it's just only plateaus for the 3 months. So we will compare with is any total IgE decreasing, and quite surprisingly, we just don't see the decreasing for all these 3 groups, but still they don't have any significant decrease for the total IgE. But if we measure for using the skin hypersensitivity reaction to the hot dust mite, because all these 240 AD child were sensitive to the hot dust mite, and then they were all decreased for their skin prick test. So it's more effective than in not just on the cellular immunity, on the cellular immunity, and the human immunity for the IgE production is somewhat is just only have a little affected, but still for the T cell, they have found it's very quite promising. And then this is more on the T cell reactivity have been decreased after a probiotic treatment. And the most surprising is that we found that we provide lactobacillus, and we in the stool collected during this period, we found that there were increase for the bifidus bacteria, and then a decrease for the Clostridium. So actually, if we provided the probiotic for lactobacillus, they can somehow change for the composition for the other beneficial bacteria. So we are more interested in what is the really mechanism there. And then we know that atopic dermatitis have a skin barrier disruption, and the hot dust mite have quite effective to disrupt for the skin barrier. So we don't need IgE sensitization. We just only exposure to the hot dust mite that cause the skin barrier disruption, and they will increase for Th2 inflammation. So we use this mice model to exposure to the hot dust mite. We found that the skin will also will appear like in the clinical condition. They have a scaling and also a reddish, and also the skin have a lot of eosinophil infiltration there. So we use this mice model for atopic dermatitis, and we tried it using our lactobacillus for the low dose and also high dose. So you can see from the gross picture, if we using the OBA as a sensitization or hot dust mite, the skin will become rough, and also thickness and also some of the scaling. And if we using the 10-7 or 10-9 doses for a CFU for probiotic that will keep the skin in the smooth condition. And then we found the skin physiological condition for the hydration or pH and pH value or transepidermal water loss. They're also increasing and also improving for the atopic dermatitis picture. So you can see from the epidermis and also dermis thickness, the AD induced by the OBA, they will increase for this skin layer, and using the administration for the probiotic, the skin layer will decreasing, and also the eosinophil cell infiltration also decreases after probiotic treatment. And then we found that some of the non-cancer cell degradation or infiltration will also decreasing after probiotic treatment. And previously we know that atopic dermatitis have a skin barrier disruption and skin epithelial inflammation to produce a lot of TSLP, and a lot lactobacillus can decrease for the TSLP production from the skin barrier. And previously we found that lactobacillus gastrui can go through the PPAR gamma activation that also can decrease for the inflammation cell infiltrated to the lung. So we asked the question, what is the component for the lactobacillus that will have an increase for the PPAR gamma and also can have an anti-allergy effect? And then we found one of the protein that is one of the dehydrogenase, we call it LGB40. And then we purify from our lactobacillus gastrui and clone in the E. coli. So we got a lot of lactobacillus product that is we call the LGB40, that is the peptide. And we have a mixture in our mice, and we found they can decrease for the asthma. So we asked the question, if we provide LGB40 that will purify for the lactobacillus gastrui, is it possible can also improve for the atopic dermatitis and even for the treatment? So if we just only using the LGB40, and you can see the skin in the mice all decreasing and become smooth, and all the thickness for the epithelial cell will also decreasing, and for the lung cell infiltration will decrease after LGB40 injection. And more important, we found that a lot of epithelial cell in the atopic dermatitis that will increase for the apoptosis. And if we using the lactobacillus, that can decrease for the M30 expression. That is the marker for apoptosis. And this is using flow cytometry. And we found if we provide this peptide from the lactobacillus, they can decrease for the apoptotic cell. So this is my final slide to have a summary. We found that if we using the OBA or using the hot dust mite attached to the skin barrier, they will disrupt for the skin barrier function and increase for inflammation by the increase for TSLP and also interferon gamma and our 17 cell cytokine. And if we prevented administration for the lactobacillus gastrui, so we can keep the skin barrier function and decrease all these cytokine. And even we provide for the LGB40 peptide, they still have a very good effect and to prevent the atopic dermatitis and decrease for transepidermal water loss. So the clinical, we actually Professor Rupi Pawankar in the previous lecture have spoken about how the probiotic in the meta-analysis is highly recommended for, in the high-risk pregnancy mother and using during their infancy. But after that, maybe the effect will lower. So at the present moment, we have to look up for the probiotic, what is the species strain, and what is the really mechanism for their anti-allergy effect produced, particularly in the treatment for the atopic dermatitis. So in Taiwan, recently we have conducted a hypothesis that using the birth cohort, our hypothesis is that if we want to prevent allergy disease, we have to study in the early pregnancy. So this is our South Taiwan allergy research to conduct the birth cohort, follow up for 6 years of age, and we use the probiotic before during their pregnancy, and we hope that we can have a very good effect and prevent for allergy disease to develop. So I will thank you for your time, for your attention, And the final slide is that we wish you to attend 2021 APAAACI International Congress that will join with the Taiwan Allergy Society. And then this menu will help in the Kaohsiung, Taiwan. We hope at that time we don't use the teleconference and we can all welcome you to visit Taiwan. Thank you for your attention.
Thank you, Professor Wang. There will be a question, of course. We are coming to first from Dr. Anggi Yuliani Utami. Professor Wang, is there any study that microbiota has reaction with certain micronutrient and certain antioxidant specific characteristic in each organ like skin, lung, gut, and maybe the brain? Thank you.
Yeah, it's a very good question. Actually, this is a whole new study and a very hard research area at the present moment to look up in the different organ. It's a different microbiota will affect because particularly for the immune system. At the present moment, we don't know. We don't know what is the relationship between the gut microbiota or the other organ microbiota. But still, it's a lot of studies have shown that this microbiota if they have a different diversity or even different strain will come out, will really have some of the effect to increase the incidence for allergy disease or the other chronic metabolic disease such as like obesity or even diabetes or even the autism or even the other Alzheimer's disease have also shown that some of the microbiota, not just only gut microbiota have changed, the local microbiota also changed. So this is a quite new study at the present moment, and presently a lot of questions we cannot answer that. Okay.
Thanks, Dr. Wang. The second question is from Dr. Grace Lydia.
Yeah.
How do we know that one person needs more than another? Is there a special lab examination test for this? Or should we eat multi-strain probiotic?
Okay, it's a very interesting question. Is that is it possible that our host so-called genetic difference, is it possible to also affect the colonization for our like a gut microbiota or maybe skin microbiota were different? Actually, we don't know at the present moment. But according to our unpublished study, we found that some of the genetic difference will really have will affect the different colonization for the microbiota. So each person have their unique composition for their own microbiome. So at the present moment, we don't know how to categorize it. And maybe they also show the different clusterization, so-called like endotype for the microbiome. For example, for the allergy, we know that previously we saw asthma is just only so-called extrinsic asthma or intrinsic asthma, depending on their allergy type. But at the present moment, we know that a lot of endotype for asthma, difficult to treat, obesity-induced, exercise-induced. So this is a lot of endotype. But maybe in the future, we will also categorize by their different cluster for the microbiome. And maybe they also will tailorize, they will personalize, become a personalized medicine that will use a particular probiotic that will more effect on certain patients, but they didn't have any effect on the other population. So I totally agree that maybe the population different also need a different probiotic to treat. But at least we don't have anything. Sorry.
Thank you. Now from Dr. Ajit, for how long should preparation of probiotic be given to a child with allergy?
I would suggest that some of I think my talk is want to focus is there was a golden time window, that is during the childbirth until 1 year of age. This is a very important stage that if we give the probiotic, then maybe have a lifelong a beneficial effect. But after that, if we give the probiotic, it's just only temporary. So we need a daily supplement. If we didn't give them continuously, they will gut microbiota or gut microbiome will back to their original one. So this is a very interesting question, and also interesting situation. So I will say it depends on what is the age for your patient. If the patient already quite old, more than 3 years old, they will have to use the probiotic continuously. But before that, maybe using the 1 or 3 months probiotic, you can see the very good beneficial effect coming out.
Discussion, and thank you also for your presentation.
Thank you very much.
Now we invite Professor Alexandro Jochi, please. Professor Jochi is Director of Allergy at Pediatric Hospital in Bambino Gesù, Rome, Italy. He is the author of WOW Pragma and Guideline of Cow Milk Allergy. He is inspired of the GLAD guidance, and he is the editor of WOW Journal, and now lead the Food Allergy Committee of WOW. Please, Professor Jochi.
Thank you very much. Thank you very much for the floor, and thank you for the invitation to be virtually in Indonesia again. I visited Indonesia in 2018 and 2019 for meetings, and I know the cultural level of the Indonesian colleagues in allergy. So I have to share with them some information about oral immunotherapy in food allergy, and as they are of a high cultural level, they asked to me to speak about the concepts and in particular the evidence of oral immunotherapy. I think that this practice is really interesting because it's changing the complete management of food allergy in the countries and in the center where they do it. These are my disclosures, as you can read, and the objective of this lecture will be to assess basically the state of the art in oral immunotherapy for food allergy, identifying the possible patients and judge the readiness of your facilities to do it. Oral immunotherapy for food allergy is needed when avoiding food allergens becomes difficult. In multiple food allergy, situations like that are absolutely possible, and everybody in the practice knows how frustrating it may be for people suffering from food allergy to deal with their everyday diet. It has been reported in the United States that children with egg or milk allergy report experience 1 or 2 reactions per year due to accidental exposure. But older children and adolescents with multiple food allergy may experience more reactions. In this recently published study, 15 children of a mean age of 12 years reported 47 reactions over 4 months, indicating more or less 1 reaction per patient per year. More or less severe, it's very clear that these reactions may deeply influence their life. the number of reactions thus may increase with the age, with severity, in particular in adolescents, and these children are those requiring a food desensitization or a food immunotherapy. This was known also 100 years ago. Egg desensitization, for instance, was reported as a case report in the Lancet in 1908. At that time, the idea was to do food desensitization in the same way that they did respiratory allergen desensitization, thus using parenteral way. The further research shown that this way is really dangerous, and the subcutaneous immunotherapy with peanut was reported in the late 90s with a high number of severe adverse events, and in particular determining severe anaphylaxis. Thus, this way was abandoned, even if now we have some subcutaneous studies underway, in particular with hypoallergenic foods, recombinant parvalbumin, chemically modified peanut extracts, and for the most severe food allergies. In the 80s, the idea of doing food immunotherapy by oral route was raised by an Italian researcher, Giampiero Patriarca, who did the first studies on oral immunotherapy. He was very productive in the field, as you see, and Giampiero Patriarca is still active in the field in Rome. And after his studies, other Italian groups followed, proposing oral immunotherapy not only to adults but to children, not only for persistent allergy but for non-persistent allergies as milk allergy or egg allergy. And the idea from Italy spread in Europe, into Europe, and in France, in Germany in particular. Studies with oral immunotherapy were published starting from 2005. The effect of these studies was found of importance, and studies on oral food allergy are reported now since 2010 in other parts of the world, in particular in the United States, in Canada, in Japan. The problem with these studies is the balance between safety and efficacy, as we will see in more practically in a moment. The title of my presentation is Concepts to Evidence. How can we get evidence in food allergy oral immunotherapy? If we use the grade magnifier, you know that the first step of a grade process is to get a PICO scheme. PICO means that the effect of a treatment may vary according to the population, the intervention, the comparison, and the outcomes. Regarding the population, there is an heterogeneity of study populations in oral immunotherapy. And these, of course, make difficult to apply the available evidence to all patient groups. Look at this example, for instance. This is the Palisade study published in the New England Journal of Medicine 1 year ago, 2 years ago now, and you see that the effect of peanut oral immunotherapy are clearly evident in the group of younger age and not evident in the group of older age. They are not significant over 18 years. Thus, this poses the problem of the different effectiveness of oral immunotherapy in different populations. The intervention is not homogeneous in the studies. We know that different intervention may impact on the risk-benefit equation for patients and for doctors. And in this case, we are right in the case where we have different interventions. Oral immunotherapy vary for amount of exposure, for type of food, for allergen form, for different dosing regimens, for different maintenance dose, for different duration. So there are a lot of factors making difficult to homogenize the comparison of the interventors. Also, the comparators are heterogeneous. Some studies assess oral immunotherapy against standard care allergen avoidance. Some studies are placebo-controlled. Some studies are compared to retrospective controls. If there are structured systems to collect adverse events data, this may lead to an overestimate of adverse events. And finally, the outcomes are different in different studies. This is particularly true if we look at the outcomes of the peanut oral immunotherapy studies. Some of these studies are aimed to desensitization. Some are aimed to a complete acquisition of tolerance that is called sustained unresponsiveness. Some assess the health-related quality of life, the disease-specific quality of life. Some are aimed to the safety or health economic analysis. So the definitions are different. The lack of an homogeneous definition of severity of food allergy and of tolerance across studies makes these further complicated. In general, the outcomes of the studies are clinical desensitization or clinical tolerance. The essential difference is that the patient desensitized may tolerate more food than before the treatment during the treatment itself, while a tolerant patient may be defined as a patient that may tolerate the food not only during the treatment, but also after the completion of the treatment, But just lacking to this definition, we have difficulties in assessing what is clinical tolerance, how long should it last, and which kind of tolerance, and this sustained unresponsiveness, how long will it last. These outcomes of the studies have been assessed in several studies. In this meta-analysis, for instance, of oral immunotherapy for IgE-mediated cow's milk allergy, we can see that the probability of achieving full desensitization is significant, 10 times higher in children on immunotherapy versus placebo or not immunotherapy. And also the probability of partial desensitization is significantly higher in children treated compared to controls. But we are not really sure that what patients want from an oral immunotherapy is to increase their thresholds. According to the NIH meeting with patient associations held in 2009, the really sought after outcome by patients is to reduce the manifestation of food allergy outside the provocation test setting, because what they need is to go safe in their life, and if possible to have a long-lasting sustained responsiveness, that is to get rid of food allergy. There we see a disconnect between the patient expectation and the study outcomes, and if we measure the patient expectations in our studies, we can find some surprise. I know not well, but I have been a couple of times in Indonesia, and I know that there are some colleagues wishing to apply oral immunotherapy. which are the possibilities and the difficulties? First of all, Indonesia do have a rate of food allergy probably similar to the rate of developed countries. The most important food allergens are cow's milk, egg under 5 years, seafood, egg and nuts over 5 years. The main problem that Indonesian colleagues reported to me in their practice is the fact that during oral food allergy immunotherapy, there are the necessity of an induction period in hospital with several hospital sessions. In this scheme reported by a Japanese group, you see that at least 5 days of hospital stay are needed to get some initial tolerance. And then during all the maintenance phases, the doctors have to stay connected, to stay available 24 hours a day with patients to evaluate possible reactions. Thus, this may be difficult. And the second problem that is reported is that doing oral immunotherapy may have an unacceptable number of side effects. To assess these aspects, with the McMaster group of Derek Chu, we did a study that was published last year in The Lancet on oral immunotherapy for peanut. We reassessed all the studies published on oral immunotherapy with peanut at this point, including the Palisade study. And the conclusion of the Palisade study was that a peanut treatment called AER 101 was effective in desensitizing children if ingested without those limiting symptoms. In this study, also in this study, I apologize for these numbers, the overall side effects reported were higher, significantly higher in the treated group compared to placebo. See here, 367 against 118. And this was true both in the initial dose escalation phase and the maintenance phase, thus raising the problem of the practical use of this drug. Our evaluation was able to assess more than 1,000 participants with peanut immunotherapy, either by proprietary products or non-proprietary products, or peanut itself as foods, compared to placebo or to avoidance for a median follow-up of 1 year, and this focused on the side effects. As you see in these slides, in these 1,000 patients, the published patients, peanut oral immunotherapy determined a large increase in anaphylactic reactions to 22 versus 71, in the use of rescue epinephrine, 82 versus 37, and these happened practically in all studies, and the risk of anaphylaxis is significantly higher in children treated with peanut immunotherapy versus no oral immunotherapy. This happened independently of the target dose. That is, if you reduce the target dose, you do not decrease significantly the risk of side effects of allergic reactions in treated patients. This happens independently of the starting dose, indicating that also the reduction of the starting dose is not enough to reduce the risk. And this happens in all the phases of oral immunotherapy, both induction phase and maintenance phase. Thus, the epinephrine use is significantly higher in these children. Also, other side effects are significantly higher in peanut oral immunotherapy treated children. And this is true for life-threatening reactions, for hospitalizations, for dropout of from the protocols, as you can see here. So in the studies, likely to drop out if you have the drug and not the placebo. And this is true also in all organ system, that is in overall, in all system, but in particular is true for gastrointestinal systems, for cutaneous and mucous membrane adverse event, for respiratory adverse events, and for lower tract of respiration adverse events. And this is particularly true for severe adverse events and adverse events causing treatment discontinuation. Regarding the totality of these allergic reactions, you see that they are significantly higher in treated group. Also in oral reactions, you have the same figure. You have a similar figure in abdominal pain, in vomiting, and thus, in summary, with high moderate certainty of evidence, peanut oral immunotherapy increases the chance and the frequency of allergic reactions, including anaphylaxis, use of epinephrine, and serious adverse events in those treated. Thus, if oral immunotherapy is effective in increases oral food challenge thresholds, this was not able in the revised studies to improve quality of life compared to avoidance placebo. There is the risk that it worsens the quality of life. This is not completely new, because also in the meta-analysis on milk allergy, oral immunotherapy for milk allergy, back in 2012, we found local symptoms in a significant manner, but also oral symptoms with a very high risk ratio over the comparator. This is true for many symptoms, and the high risk ratios were found for oral symptoms, for laryngospasm, for the use of oral glucocorticoids, for the need of nebulized epinephrine, thus indicating that also for milk allergy there are some problems in tolerability. Thinking of a context as Indonesia, I think that in that country, in your country, is particularly true what is true in all the world countries, that before implementing a practice, you must think about equity evaluation. Oral immunotherapy is not reimbursed in any country. There are some insurances that pay for it. This probably is also possible in Indonesia, but this established a difference in the availability of the treatment between the more affluent families that can cover the cost or that do have insurances, and the less affluent families. The availability of specialized facilities is likely to limit the availability of the treatment, in particular in jurisdictions where fewer resources are available. This impact may be huge, in particular in countries where the national health system doesn't cover all the aspects of the care. So I think that implementing oral immunotherapy in Indonesia may incur practical problems. In Europe, the situation is different. We have APAAACI guidelines that are able to evaluate the efficacy during treatment, and a meta-analysis of all treatments with oral immunotherapy, not only peanut, but also egg and milk, was able 2 years ago to show that there is a good probability to get an increase of the thresholds, But again, also in that meta-analysis, the trend for longer-term benefit of oral immunotherapy was not significant, indicating that oral immunotherapy may get desensitization, but not sustained unresponsiveness. There have been debates, in particular in the World Allergy Organization journal, on these aspects in oral immunotherapy in general and peanut oral immunotherapy in particular. And I think that the conclusion of the European guidelines may be useful also in other parts of the world. And they recommended oral immunotherapy as a treatment option in children with persistent cow's milk allergy when aimed to the getting increase of thresholds, but they don't recommend it as a complete treatment for cow's milk allergy. It's not able to get a full tolerance. This is similar for egg and for peanut, thus again indicating that the possibility of oral immunotherapy is to get desensitization, but it limits is the fact that it may not modify the natural history of the disease. Regarding safety, there are local actions also reported in the APAAACI meta-analysis, as in the PACE meta-analysis on peanut allergy that I just reported to you. And in particular, from a practical point of view, you must keep in mind that the reaction to oral immunotherapy may happen when children are at empty stomach, when they do an irregular intake, after exercise, and children do exercise, during infections, concomitantly to other medication use, during menses, and so there are several conditions, in particular an IG, that may condition the side effects. And this is true in all the published studies. This is a study from Asia, again, the same study I showed you before, indicated then in particular urticaria, pruritus, rhinorrhea, and throat oral symptoms, abdominal pain may be present during this practice. Last but not least, there is a significant risk of developing EOE during oral immunotherapy in patients with IG-mediated food allergy, even if it seems that these forms of EOE are remittent with the stop of treatment. There are some other open questions. The more important open questions are the risks and the duration of the effect, but also the cost of oral immunotherapy has never been assessed, while also the cost of food allergy have never been assessed or seldom is assessed. The main problem is the correct outcome for the studies. What can I get from my oral immunotherapy? Just desensitization or sustained unresponsiveness? And the cost of treatments are also other problems. Thus, the possibility to implement immunotherapy with omalizumab is not to be discharged, is not trivial, and should be taken in account. Omalizumab is able to reduce the side effects of immunotherapy, and with omalizumab, those children that did experience 1 reactions per month got only a couple of reactions in 4 months in the total caseload. So it's able to dramatically reduce the number of adverse effects. Omalizumab, during treatment with omalizumab, the thresholds for foods are increased, and there is the possibility to tolerate completely, reintroduce without oral immunotherapy foods under omalizumab, while some introduction may be done also for other kind of foods, and the threshold is increased both for wheat and egg, and for milk and baked milk. Thus, this drug is highly effective in increasing the thresholds. In conclusion, I think that when dealing with oral immunotherapy, the clinician must be very careful in considering the values and the preferences of the patients. Those patients who won't get an increase of thresholds may be placed in oral immunotherapy. They place a high value on avoiding serious effects from ingestion of the foods. Those that place a high value on achieving tolerance, they may be exposed. But if you are a prudent doctor of a patient very able to avoid foods, you don't want oral immunotherapy. With this consideration, I conclude the presentation, and I thank you for your attention.
Thank you, Professor Fiocchi, for your interesting lecture. Since there is no question yet, so maybe may I ask you a question? Could you tell me the difference between tolerance and desensitization?
The question is about the definition of tolerance and desensitization?
Yes, right.
Okay. Desensitizations mean that during the treatment, the thresholds are increased. Tolerance means that the thresholds remain increased also after the discontinuation of the treatment. Those children desensitized are children that tolerate more food while taking oral immunotherapy, and those tolerant are those that completely are out of their disease. These are the two main outcomes for oral immunotherapy.
So in oral immunotherapy for food allergy, you have tolerance.
Yes, we can get tolerance in the majority of cases, because there are also cases in which you cannot get tolerance because of dramatic side effects at little doses. And these are exactly the cases of children more in need of oral immunotherapy.
Is it you have find permanent tolerance or temporary tolerance?
This has not been clearly demonstrated for any kind of immunotherapy. There are some studies assessing the immunological modifications after oral immunotherapy. These studies are able to show that there are immunological modifications, but it is not clear if these modifications are sure they are the effect of the exposure, if they make for tolerance or not. Sometimes they just witness the exposure, and that's all.
How could you do oral immunotherapy if the patient had multiple allergens? For example, like from cow milk or eggs or...
Thank you for this question. This is a very interesting question. This makes difficult to do it because oral immunotherapy is highly specific. For instance, if you desensitize a child for cow's milk, she can remain allergic to sheep milk, for instance, or to goat milk. This is highly specific. In case of multiple food allergy, there are clinical experience published of desensitization with multiple food blends. This could be the way to do it, but of course this is the case in which I would wish to use omalizumab. The problem is omalizumab is the cost, of course.
Here's a question from the audience, from Dr. Rudy Anwar. Professor Alexandros, sorry. What kind of agent or AP used in oral immunotherapy?
Can you repeat this question? I didn't catch it.
What kind of agent or API used in oral immunotherapy?
The question is the kind of epinephrine used in immunotherapy. I think so. If so,
API? I don't know what API. Yeah. Sorry.
No,
what kind of agent? Agent is maybe an allergen.
Of kind of agent. Excuse me, Professor, I am not able to catch the meaning of this question. If it's EPI, is epinephrine, and of course you use epinephrine as in other food allergies. Maybe Ruby, can you clarify?
I think he's trying to ask what kind of like we have allergen extracts. So what kind of just one second, I'm having some problem with my. He's trying to ask that what kind of like for egg, what kind of form would you use for immunotherapy?
Okay.
For example, or milk, because I think that's what he's asking, because for aeroallergens you have extracts, so that's why he's asking.
Yes, this is variable with different studies. So for instance, for egg, some use raw egg, some use baked egg for immunotherapy, and the effects may be different. You know that in order to standardize the intervention, there is some companies now studying standardized extracts of foods as drugs, and this is of big interest. The first drug for immunotherapy is now available is now approved for use in the United States, and it is a pill for peanut immunotherapy.
Can I ask a question?
Yeah.
Yeah. Alexander, thank you very much for the excellent lecture. And I think this is one of the very important future areas for food allergy. I was just wondering that is there a role for immunotherapy early, more like now, like we have the GLAD-P, which was basically designed with the intention of looking at whether we could prevent any allergies, not just food allergy, but whether there's any evidence for any preventative strategies. So do you think that oral immunotherapy could be used like as a primary prevention at some point of time early in life to people who are at high risk through some even before they are introduced to the foods?
Yeah, of course, this is a very important question. This is not oral immunotherapy, but oral immune prevention, and the attendance.
That's correct.
Yes, the attendance knows that there is now a change of paradigm in this field. Traditionally, we used to think that a late introduction of allergenic foods was associated with a reduction of the tax of food allergy for the respective foods. The LEAP study and the EAT study and other studies published between 2015 and 2019 are showing that the opposite can true, at least in some subpopulation of patients. Early introduction of peanut has proved to be effective in the reduction of peanut allergy in UK and the United States. Early introduction of egg has been also proposed and suggested, and is now recommended by the recommendation of several national societies. But this seems not to be true for all foods. In particular, it seems not to be true for milk, it's not for nuts, not for fruits, and not for fish. The situation is complex, and we cannot conclude that every food must be given early to prevent the respective food allergy. And in particular, we cannot conclude that the early introduction of the foods shown to be effective in prevention must be implemented in all the countries. For instance, peanut allergy is prevalent in the United States, in the UK, and maybe in some other countries, but not in Europe, not in Southern Asia, not in Indonesia. And so I think that the LEAP strategy should not be implemented in that country.
Can I ask another question, Professor Heru? Can I ask another question?
Will not be discussed in the panel discussion.
Okay, okay.
Yeah. Okay. Thank you, Professor Fiocchi. We still have 20 minutes for a discussion. So now I invite Professor Kalina, Professor Ruby, Professor Wang, and Professor V to have a panel discussion, and also the audience. Yeah. So there's a question. How do we, it is from Dr. Radia, how do we know that what strain need one person need more than another? It's already mentioned. Yeah. So this is for Professor Fiocchi. Do you use commercially made preparation, or do you make preparation on yourself for oral immunotherapy?
Thank you for the question. In Italy, we don't have commercial immune preparation available yet. And to my understanding, there are no immune preparation, commercial immune preparation available anywhere. There is, maybe Kalina may correct me, but there is the approval for the use of AR 101 in the United States. And I think that it will be soon commercialized.
Any comment from other speakers?
Yes, sorry, can you hear me?
Yes.
Yeah, I think that's a question that I always like to ask the doctors, because, you know, the commercial product, of course, is perhaps a bit safer because you can really have exact measures of those very small amounts, like when you give 1 milligram or 10 milligram, but the cost is very high. And, you know, you can buy many jars of peanut butter for the same cost that you buy the Palforzia product. And so I think it will be interesting to see in the next few years whether people use the commercial one at the high cost, but more safety and more exact measurements, or whether they're going to use cheaper options, which may not be that exact. I think it will be interesting to see what happens.
The speaker or moderator? Yes, please, Professor Ruby.
Yes, my question again is to Professor Fiocchi, and you know, now with this epicutaneous form of desensitization or immunotherapy, I mean, there may be other forms also coming up in the future, but the chances of anaphylaxis would be less, I would presume, as compared to oral immunotherapy. I know there are no head-to-head studies done looking at that, so unless you have head-to-head studies, we cannot say it. But just what would be your general opinion about the future? Would you think it would be safer to have something that's more through the skin, or the conventional oral one, even if it's in combination with omalizumab?
Yes, thank you for this question. It's important from a practical point of view. As also you know, as also Professor Venter knows, we are reviewing this matter in a meta-analysis and for the formulation of guidelines in the field of milk allergy. So we know exactly that the effectiveness of the epicutaneous forms for the moment seems to be less than the efficacy of oral immunotherapy, while the side effects are absolutely negligible in that case and limited to local effects. So I think that there will be a way for a safe safe epicutaneous desensitization, and in this case, we cannot exclude that given the particular mechanisms of sensitization to foods, the goal to getting sustained, definitive sustained responsiveness could be met. So it's possible that that way allow us to modify the natural history of the disease. Of course, only the future will tell us which is the best option, but I think that this kind of immunotherapy must be seriously considered at the moment.
Yes, Ruby, there's no more question?
Yeah, I'm letting the other people ask, and then I can.
Thank you. Here's a question from the audience. Professor Fiocchi, is there any difference between oral and colon immunotherapy regarding the effectiveness of the immunology therapy? I mean, why you choose oral rather than rectal? Professor Fiocchi?
The question is about oral versus rectal.
Yeah.
I think that there are only one study on rectal immunotherapy, and this has been done by the Samsung group in the mouse. So I think that rectal immunotherapy has not been developed yet. But the rectal exposure is very effective in getting tolerance, in getting food reactions. We know from anecdotal episodes that the exposure by that way is very effective. For instance, we also follow APAAACI, and got a very serious APAAACI reaction in a child allergic to rice by the administration of a rectal suppository for constipation that was made by carob and rice. So the question is not trivial. I think that this is a good suggestion for the future. It may be.
This question for Professor Wang.
Yes.
Yep. There are many different strains in microbiota and probiotic. So what is the best? Or you just use multiple bacteria?
Right. I think this question is very important because at the present moment, we don't know what is the best strain for probiotic to treat atopic dermatitis. It may be depend on the host factor, or it may depend on the bacterial strain, and maybe also depend on the doses. Also, maybe also depend on the when are you going to prevent atopic dermatitis, or you just want to treat it for the atopic dermatitis. So at the present moment, we don't know what is the real one, the best strain for atopic dermatitis. But I will just only recommend it must have a clinical evidence to show that it really have any efficacy. And then the other is about the combination. I think the combination may be better than just only one strain. But if you just only use the lactobacillus for example, maybe using a 2 or 3 strains for lactobacillus, it may not have a better than just only one lactobacillus. But if you combination for the different phylum or family, such as one lactobacillus or using and combine with the bifidus, that maybe have a good more efficacy than in the prevention or treatment for atopic dermatitis. So at the present, evidence just only show that the combination may be better than just only using a single strain.
Thank you.
Can I ask a question?
Yes, question.
So I have a question for both Dr. Wang and Dr. Fiocchi, and it's something that Dr. Pawankar already mentioned, and I'm totally perplexed with it, is that we find when we look at the microbiome, we find some preventative effect on atopic dermatitis, which we sort of like know is the beginning of the atopic march. And so we would expect that if we can prevent atopic dermatitis, we will prevent food allergy, we will prevent asthma, and we will prevent allergic rhinitis, but we don't see that. So I know they won't have the answers, but do they want to speculate on why we only see that effect on atopic dermatitis and then we see nothing further?
Okay. Maybe I can answer first. Maybe after that, Professor Fiocchi will answer for his opinion. According to my personal thinking, is that maybe the probiotic have a different effect. Some of the probiotics, such as using the lactobacillus like LZZ, that is very effective for the skin allergy disease, but it's totally ineffective. But because in Taiwan we have using the LZZ to administrate in the allergy asthma, but actually it's really no effect. But if you using the other strain, somehow they have a more effect than LZG. It may be regarding to the diet, because in Asian people, they have used a lot of different variety of diet. We have a lot of chili or the other such a different kind of or cuisine of food that is different from the Western one. So I think maybe geography, host factor, and probiotic strain have a different effect in the different period, because we know that allergy disease is a very dynamic one. So in the different stage, maybe some of the different probiotics were more effective at a certain period. That is just only my guessing. But actually, we found that they really have a strain difference, that some of the strain were more effective in the asthma, or the other is more effective in the atopic dermatitis.
Enough, Professor Kalina?
No, I was just going to ask Dr. Fiocchi the same thing, if he's got a different view on why it doesn't work for everything. Because, you know, you think if you can stop atopic dermatitis, you'd stop most things. But Dr. Wang gave me some really good reasons on why it doesn't work. I was just wondering what Dr. Fiocchi's view on it is.
Karina, thank you. This is a very difficult question to answer. Of course, you know it. I think that basically the reason why it appears to be an effect in atopic dermatitis and not in food allergy or asthma or rhinitis is that the meta-analysis found this in several studies. So it seems that is quite a solid fact. The fact that from atopic dermatitis you cannot prevent other aspects of the disease may not be true according to the meta-analysis, because the meta-analysis was not powered for that. But it appears to be solid according to our common experience. And this, of course, challenges the very concept of atopic march, because atopic march indicates that atopic dermatitis is really not the trigger of the disease, but only an early manifestation. So one interpretation may be the interpretation that already Ruby suggested, that is, as the observational time of the study is limited, they are able to catch only the observation of the first part of the atopic disease. This is a good interpretation. I think that this is a possible interpretation, but of course we cannot exclude, and it's very likely that the effects of probiotics are very limited in the spectrum of diseases and very limited in the time. Conversely, I must observe that also a reduction of atopic dermatitis by 10-15%, as we found in the GLADP guidelines, may be of a deep impact in a country where of 200 million of people, where there is a good natality, and this may deeply impact on the general health of such populations.
Can I make a comment, Professor Heru?
Yep, please.
I fully agree with what Professor Wang and Professor Fiocchi said, but the two things that comes to my mind. I mean, when we talk about one airway and one disease, this was something that was studied in the PAT study many years back, where you could actually prevent the development of asthma in 50% of the children who were given immunotherapy for 3 years. And so there was a window of opportunity of preventing lower airway disease. Now, whether that is just related to an atopic condition, or it's just because it's the upper and lower airway being linked, causing that kind of breakage of the impact of upper airway on lower airway, that's not, there's no hard and fast evidence on that, but definitely it shows that you can. But my point here is, like what Professor Fiocchi and Professor Wang also said, I'm just thinking, like, most of the studies have looked at, asthma, or they've looked at different endpoints. If we need to actually follow up in those children where we were able to prevent eczema, do those children go on to develop asthma or food allergies and so on? That's crucial. And more than asthma and rhinitis, I would at least think that one window of opportunity might be food allergies, because from a clinical point of view, and I'm sure Professor Fiocchi and Professor Wang would also agree, in children with food allergies who have eczema, controlling the eczema and keep good skin care helps in actually reducing the severity of the food allergy. I mean, I just wanted to hear your opinions, but we always try to tell the mother to have a good skin care, and we try to control the eczema, and that itself does improve upon the severity of the food allergy. So just an open question that Professor Fiocchi and Professor Wang can comment on.
Ruby, I really am not sure that a good care skin may act in prevention of food allergy. There has been some studies on that aspect, strongly suggesting it, and these studies were not able to show any effect on the development of food allergy. So I think that the relationship between the different forms of atopic disease are complex. Yet, of course, this is one disease. You told this is not only one airway, but one child, one parent, and one is. But the relationship between the different aspects are different. I think that we will not be able to answer these questions until we have not a clearer idea of the genetic background. To my understanding, I tell you this as clinician that see children every day with these complex these situations. There are different aspects of the manifestation of the disease. Some children have multiple food allergies, severe atopic dermatitis, and severe asthma since their first year. These children do not follow the allergic march. They just are born with a severe form of food allergy, and these children are those more difficult to follow. Other children do have lighter forms of allergy, and they have successive forms. So for instance, in my opinion, we have the probability to be effective in this layer of children. So the efficacy of the preventive effects probably must be evaluated phenotype by phenotype, and this has never been done.
I think I can add something to that. So I haven't submitted the paper. It needs to be out for peer review. So I may be wrong, but I've just looked at data on maternal diet and how it affects infant allergy outcome. And it's completely, the effect we find is completely modified by whether the child has the filaggrin loss of function mutation. So, you know, it fits in very well with you. It's that it's not just perhaps what you eat or whether you take the probiotic and disease outcome. You know, we really need to study the middle bit too and look at different genetic profiles, because it may affect outcomes too. But my other thing, and I'm not trying to take away from the science, but I wonder sometimes whether we see the effect between diet and atopic dermatitis, or diet or probiotics and atopic dermatitis because of power. You know, we have larger numbers of atopic dermatitis than we have for food allergy or asthma in that very young group. And so when you look at your numbers, you always have the highest numbers in terms of cumulative atopic dermatitis over the first 3 years of life. And I sometimes think the numbers we have help our power, and therefore we're more likely to see significant statistical outcomes than what we would see with the other outcomes. So I think that's something we need to take into account as well, because, you know, you're going to see 30 to 40% cumulative incidence of atopic dermatitis by 3, but unless you live in Melbourne, you're going to have only 3 to 5% food allergy, you know. So I sometimes think your numbers on food allergy is so much lower than atopic dermatitis that it's hard to do that statistical analysis and get your significant p-value. That's just something I was wondering about as well.
Thank you, Professor Kalina. We have a limited time, so we have to close the interesting discussion.
Good.
Now, my time is back to Dr. Indrajana.
Patrick.
Patrick. Yeah.
Thank you very much for all the professors, for the speakers, for the very, very interesting discussions and so on. But unfortunately, the time has constrained us to limit this this webinar. So once again, I would ask to invite Prof. Ruby. Would you promote this Congress for next year?
Yes, thank you very much, Patrick. And once again, I thank Professor Iris and Professor Heru and the Indonesian Society for giving us this wonderful opportunity to have this joint initiative with APAAACI. And as Professor Wang has also, I had missed showing in my last slide because I was a little bit afraid of the time, but as Professor Wang has also shown, we have our next conference. That is our new initiative, which we will have in every interim here. We have the next APAAACI conference 2021, like the one we had in Beijing last year on October 15 to 17 in Kaohsiung, Taiwan. And Professor Wang and myself with the local chairs and co-chairs will work together to welcome all of you and hopefully we have a very good scientific congress. And I also welcome you to the APAAACI 2022 Congress. That is our biennial Congress, which we missed having this year. So it'll be once, actually after 4 years, that we will have in Manila. That Congress will be held jointly with the Philippine Society of Allergy, Asthma and Immunology, because it's also their 50th anniversary. So looking forward to welcome you all there. So please come to both the conference and the Congress. And I would like to thank all the speakers Professor Kalina for her excellent talk on diet. I'm always impressed by her talk, and really she's done a lot already for APAAACI. I thank Professor Wang not only for his speech today and the excellent science that he has shared, but also for being a fantastic president-elect and really being my teammate in actually running the organization. I thank Professor Fiocchi very much because I've known him for years now, even before I became the president of WOW. But we worked a lot during my presidency. Also, in fact, the GLADP was initiated during that time. It was my dream project, which was led by Professor Fiocchi and came up from the first initiative started in 2003 that Gunnar Johansson had done with WHO on prevention of allergy. And that is also a document and an initiative in process because there are several more aspects of it that need to be done. And his talk, as always, has been excellent. We also thank him for being an advisor to our food allergy committee and for all his valuable contribution to it. So with that, I'd like to end my greeting.
Okay, that's all conclude with the webinars today. And thank you for all the participants. We have so far at least more than 400 participants that constantly join from the beginning. Thank you very much. And hopefully we will see you again, maybe on offline event. Thank you very much. And